Welcome to another episode of Electable. I'm Deb Chubb, and today it's all about abortion. And we are just very blessed to have with us Dr. Caitlin Bernard. She has become famous in Indiana for being a compassionate abortion care physician. She is technically an OBGYN and also certified as a complex family planning doctor. And I'll ask her to explain that as we go forward. But we want to talk about abortion. And we know that when we're talking to people about abortion, we are faced with a barrage of ridiculous myths that have been dreamt up by people who are opposed to women being treated as full and equal citizens in this state. And so we need to figure out how to combat all of those crazy myths. And so anyway, I want to introduce Dr. Caitlin Bernard. And Doctor, can you please just tell us a little bit more about your position and what you do?
Sure, thanks for having me. So I am an OBGYN, which means I did medical school and then residency in obstetrics and gynecology. And then I did a subspecialty training in complex family planning, which focuses on as it says, complex abortion and contraception care. Primarily focused on taking care of people who have medical conditions or otherwise complicated pregnancies that may require abortion care, as well as contraception. So both the prevention and management of complicated pregnancies.
Well, and I'm sure it is complicated. Pregnancy is a very complicated, and so we know that you became famous in particular for this year for trying to make the public aware about the realities of abortion, about the compassionate care that you provide in helping a 10-year-old, and so who was pregnant. And so I want to ask you. And I know, we have talked and you have said, there are lots of things that make pregnancy dangerous, not just being a 10-year-old. But I wonder if you could speak to that just for a moment to say, why is that particularly dangerous for a 10-year-old to carry a pregnancy to term and give birth?
Yeah, so pregnancy in young people is always quite challenging, not just regarding kind of the circumstances of how they became pregnant, which obviously can be from abuse or rape, and the psychosocial factors and psychological factors that may result from that type of a trauma, but also the underdevelopment of their bodies and the difficulty that poses to carrying a safe and healthy pregnancy, both for themselves and for the developing fetus. Certainly one of the biggest concerns that we worry about in pregnancy is something called preeclampsia, which is much more likely in someone who is so young and in their first pregnancy, and that can cause multi-organ failure, harm to both the kidneys, the liver, the heart, the lungs, the brain, can result in stroke, seizures, and death. It's one of the most common causes of maternal mortality, throughout history. We have good ways to treat it now to prevent those severe complications, but it often requires early delivery, which may be complicated, again, both for the pregnant person and the infant, especially when that occurs, preterm, with poor development of the fetus. And then we, look at certainly things like damage to the uterus and the pelvic floor, and the, vagina, depending on the route of delivery. Definitely an increased risk for things like cesarean delivery, which, can cause complications, things like bleeding, infection, and then, of course, long-term scarring of their uterus that will impact, their potential pregnancies for the rest of their life. And so, it's something that we take very seriously and, definitely want to counsel everyone about what their risks are during a pregnancy, in that circumstance or any other, and make sure that they understand and can balance the risks and benefits for themselves to make a decision that's best for them and their families.
So, well, it sounds awful. And I know that I mean, I know that when talking about abortion, women have been faced with that myth that it's fine. It's fine to have a baby when you're 10 years old. And of course, and you have mentioned earlier that there are many dangerous situations. And I mean, we all know that carrying a pregnancy to term, giving birth is more dangerous than having an abortion. That is a safer procedure, and that's correct, right?
Yeah, absolutely. I mean, I think, it's one of those things that, you can't really imagine because we see so many people, you know, having healthy pregnancies, having normal pregnancies, delivering healthy babies. But for those of us who work in this field all the time, we see lots of very difficult and tragic outcomes, including, in Indiana, very high rates of maternal and infant mortality. So this idea that there's always going to be a happy ending for everyone is just really not a reality for many different people. And the all of the complications that can occur, again, both for the mother, means that you could have a 14 times increased risk of death with continuing a pregnancy compared to an abortion. And that those, risk of death and a multitude of different factors related to, how healthy they were coming into the pregnancy, what types of complications occur during the pregnancy, whether those are something that we could predict based on, their previous health, or something that happens completely spontaneously that we would have expected. And so everyone has to, again, be able to, have those choices, particularly when they are at higher risk, to be able to determine what is best for them and their families. And abortion needs to be an option for them to prevent serious complications and death.
Right. And you had mentioned to me earlier that people in this kind of conversation that we're having all the time now have forgotten how previous to the Dobbs decision and Indiana's ban on abortion, that access still was difficult. So I remember that. I mean, I remember there was just an entire laundry list of crazy laws that had been passed that restricted abortion in any number of ways. And I fear the law that was passed a few years ago, which seems innocuous on its face, saying that that a coercion is, I mean, it was already a crime to coerce somebody to have an abortion, but that doctors now had to ask patients whether they had been coerced. And we've seen in other states where the courts and the state legislature has decided to change the definition. And so I guess I worry that coercion in Indiana may become, discussion about abortion may be considered a coercion. Have you in your practice experienced that kind of worry that people are being coerced into abortion? And I'm just throwing these out there because these are the things that people are, these are the kind of the myths that we've been faced with.
I would say, this idea of coercion or pressure, we use the term reproductive coercion. So the most, and this is something that has been studied for years. When we look at what is the most common way that women are reproductively coerced, it's actually into becoming pregnant. So that's including things like contraceptive sabotage, where their partners, and these are often, people who have a cycle of intimate partner violence or psychological abuse already, will sabotage their use of contraception to force them to become pregnant, and then force them to carry the pregnancy in order to tie them to that person and to, prevent them from being able to escape that cycle of violence. So that's the most common cause of coercion. And the challenge with the law is that it doesn't address that type of coercion at all. It focuses instead on this much less likely part of coercion, that is pushing somebody into having an abortion. But sure, absolutely, anybody can, be in a cycle of violence with a partner, or have somebody who's not their partner and being, pushed into making decisions about their pregnancy, and that's an important thing to identify, to address, to work with the person to be able to get out of that cycle of violence. So I think there's a myth that every person who comes in for an abortion, we're just like, okay, get on the table, we'll do your abortion. No, every single person goes through a lengthy process of meeting with counselors, talking through their decision, making sure that this is the right decision for them, identifying any concerns for abuse or coercion. If they are, not wanting to go through with the abortion, helping them to get resources to be able to safely and healthfully continue their pregnancy. And that was happening before this law about you have to call the police within 4 hours of identifying, abortion, coercion, and et cetera. So laws don't make the process of medical care better. We were already doing that type of, close evaluation and interventions before any law was enacted.
Well, yeah. And any other, laws before the total ban that were really impeding your really ability to provide compassionate care?
Yeah, I mean, lots of them, right? So we in Indiana have essentially all of what we call TRAP laws, targeted restrictions of abortion providing laws. The biggest one was that we were required to provide second trimester, so 14 weeks and above, abortions in an ambulatory surgical center. And there were no ambulatory surgical centers that were providing that care. So the only way that you could get an abortion after 14 weeks was to have it in a hospital, and the hospitals have lots of policies about what conditions they're able to provide abortion for. So we already had tens of thousands of people leaving the state every year to primarily go to Illinois to get necessary abortion care. And again, just thinking about who are those people who are able to get out of state. There are people who have the funds, who have the parental support, who have the partner support, who have the childcare and ability to get time off of work. And for those who don't have that, that's not an option. They're never going to be able to get that care. And they're going to be forced to continue pregnancies that are unsafe, unwanted, dangerous, traumatic, depending, on their circumstances. Parental consent laws were also very challenging for minors to be able to get safe, legal abortion care. And, as we previously talked about, there have been cases of people who have died of, complications of abortion because they weren't able to tell their parents, and they went out of state to access abortion. And so, this isn't some abstract idea of, oh, this law, maybe have these consequences. No, people are dying because of these laws. And it's, the idea that, the exceptions in our current ban are somehow going to prevent those, people from dying is just not true. There are people who have conditions that are not on the list. As we were talking about, the ACLU is currently trying to petition the court to acknowledge that mental health is health, that mental health conditions do put people at risk in pregnancy, and need to be considered as part of the exceptions at this point. Essentially the state of Indiana, their formal policy is that mental health doesn't count for a complication in pregnancy, and that anybody who's had postpartum depression, postpartum anxiety, schizophrenia, bipolar disorder knows that that is not true. And it's a incredible shame that the state of Indiana is not supporting all of those Hoosiers with mental health conditions that may impact their pregnancies.
Do you consider substance addiction a mental health condition? I mean, I just know that's connected a lot to maternal mortality.
Absolutely. Yeah. So substance use disorder, the vast majority of people who have substance use disorders or substance abuse also have mental health conditions. That's what we call a dual diagnosis. Often they're, it's a way to self-medicate, right? It's a way to deal with the trauma that they've been through. Now, whether they have a formal diagnosis of that or not, yeah, absolutely. It is incredibly difficult to separate those two issues. And yes, that is one of the main causes of maternal mortality in this state. And again, until we're able to, provide all of the care that someone needs to be able to address those conditions in pregnancy, and before pregnancy, ideally, we're not going to make a significant impact on our maternal mortality rate.
Right, right. So now I have to ask you, you are such an incredibly smart and, knowledgeable physician on all of these matters. And I have to ask, how does it feel suddenly to be kind of a political football?
Yeah, it feels bad, I guess is the short
Oh,
answer. This is not something, I don't consider any of this to be political, right? That is the furthest from what we think abortion care and medical care should be. We believe that it's a human right. In fact, it is a human right. I don't have to believe it or not believe it. People say, oh, I don't believe in abortion. It is. Whether you believe it or not, it is. Abortion care and health care are human rights. And so there should be nothing political. This shouldn't have anything to do with sides or colors or political parties. This should be something that we all agree is the right thing to do for people in this country, for people in our state. And the fact that it has become political and that it's become controversial and that I have, been in the middle of that is really just a disservice to our fellow human beings, and it really detracts from our healthy community and takes time and energy to fight for something that we shouldn't have to fight for in the future. I often say, like, I can't even imagine how much we could get done. We could literally be, curing cancer if we didn't have to spend so much time and energy on just fighting for some basic human right that is actually, quite simple and safe and easy to provide. And yet, we're wasting all of these taxpayer dollars, and time and energy on something. But if if that's what needs to be done, then I'm certainly willing to do so because I believe that we all have a responsibility to work as hard as we can to ensure those human rights for our fellow humans.
oh, you are incredible. It's wonderful. I mean, it's just wonderful to talk to you and everything. And I want to ask you too about some of the other myths that are out there, and it really are often, and you will hear politicians say it all the time. That women want to have an abortion up until birth, and I mean I'm sure that just strikes you as the most ridiculously stupid thing you've ever heard. But I mean, can you talk a little bit about abortions that occur a little later in pregnancy? I mean, well, I'll just let you describe it.
Yeah, absolutely. I mean, abortion later in pregnancy can be a difficult thing for people to understand until they're faced with it, right? Nobody ever would expect for that to happen, right? This is not some an unwanted pregnancy that decide about later in pregnancy. These are people who have incredibly horrible, difficult decisions to make, and often faced with the worst situation that they could ever imagine, the worst experience of their life, which is that their baby has been diagnosed with something that will make their life incredibly difficult, or that they will inevitably die of, either later in the pregnancy or soon after delivery, or some genetic conditions, have a horrible infancy, and die, within the first years of life. These are people who desperately want to be parents and are doing the best that they can in an incredibly difficult situation to be parents, to make the best choice for their baby that they can. And the way that our culture and society, instead of supporting them, instead of being compassionate and understanding how difficult that is, they're vilifying them. And the physicians who are doing everything that they can to support them and ensure that they have the ability to have an abortion later in pregnancy, it's really incredibly tragic, and one of the most misunderstood areas of medicine. And, again, you just can't imagine until you're in that situation. And I can't tell you how many patients I've had who said, I never would have thought I would have an abortion. I, you know, I couldn't imagine this, and now here I am. And I know that this is what I need to do. And thank you for being there. And there's lots of, if you just, look at, stories online, there's lots of people who have spoken out about their experience with this. And there's, if someone is willing to really take the time to understand, then it will be very clear that this is something that we need to be able to preserve for them.
So tell me how that, those experiences, fit with the new ban. I mean, it's, so an abortion is allowed under the circumstance of a threat of fatal fetal anomaly. And I don't, does that work in medicine? I mean, how do those words work in your practice?
Yeah, I think in some cases are very straightforward, that there's, no question that this is a fatal or lethal fetal anomaly. Things like anencephaly, where the head and the brain don't develop. And then there are things that are much more complicated. It's really difficult to predict, how severe a brain defect is, how severe a heart defect is, what the course of the outcomes would be. And so we work, closely as a team with my maternal fetal medicine, high risk obstetrics team, sometimes neonatologists or other pediatric specialists who have seen these types of conditions and know the outcomes. And we do the best that we can to make that determination for patients. But of course, I have lots of patients who have, really severe fetal anomalies that, for whatever reason, we can't be sure that it's a lethal fetal anomaly, and they're referred out of state. And they have to, in the worst, darkest days of their life, be essentially thrown out of their home state, pushed, somewhere else to be taken care of, somewhere else to travel away from their home, away from their family. It's absolutely devastating.
Yeah, I mean, I'm so sorry. I know this is so, I mean, this is just like cuts to your core. This is, you believe in this kind of care so deeply. So, and and of course, the other issue that we have to hit on is miscarriage. Um, you know, Miscarriage is kind of equal to abortion. I mean, I think medically
That's right.
speaking, it is the same thing. And
That's right.
and I think the figure is right. Correct me, of course, if I'm wrong. Is that 25% of pregnancies end in miscarriage, and that's automatically 25% of pregnancies that are aborted.
Yeah.
And that and that just an abortion in terms of a pregnancy that's failing and is being expelled naturally isn't adequate for a woman's continued health. She does have to be seen, and she does have to be get some care so that she can go on and be healthy. And so I guess I mean, that's another area where when cross the line of the law, you have, how does that, how do you juxtapose or reconcile those two things?
Yeah, I mean, many people having miscarriage care do need to be seen, do need evaluation and management, whether that's with medication, for example, mifepristone. That's that huge all the court cases related to mifepristone. It, again, is incredibly sad that we're trying to restrict a medication that's used often for people having miscarriage. And so that's one, way that restrictions on abortion care do impact miscarriage care. Another is that in order to be adequately trained in how to provide miscarriage management safely, particularly more complex cases, particularly those in the second trimester, you need to be trained in those procedures. And when we are unable to provide training for abortion procedures, which, as you mentioned, are exactly the same as those for miscarriage care, then the physicians that we're training here in Indiana and that are coming to practice here are unable to provide that care. I as a complex family planning specialist, one of two in the entire state, get referrals from all over the state for patients having miscarriages and stillbirths in the second trimester. We have patients who are, completely mismanaged in that care at other hospitals and have significant complications because of those referred to us here. And the reason for that is that they're not, getting the training and the care that they need because everyone is afraid to provide training in abortion care, and the workforce is unprepared to be able to translate those same procedures for miscarriage care. It's incredibly sad.
Wow. Yeah. All right. Well, this is a horrible state. In all the translations of the word state.
Well, I like to think of it more as an opportunity. I think we have a lot of work to do, and I can only hope that those who are willing and want to, continue to improve the care that we provide here, are motivated and willing to do so, and that we can, work together to make it a better place.
That is such a great hopeful outlook, and I too. I mean, I approach this topic as not really in a medical way, but really in a human rights and a human rights approach. Women are human beings, and as such, have the right to control their bodies and their medical decisions. And so the medical parts are difficult, and we do need to understand them. Because we are in this fight. But that is not really the main point, is it? The main point is that women are just humans. They should be treated as full and equal citizens with all the rights guaranteed in our state and federal constitutions that
and I think,
are given.
Yeah, absolutely. And I think the other part is, we don't nitpick what type of procedure somebody uses for cancer care. We don't say, oh, a medicine that's being used for diabetes treatment shouldn't be allowed. Just like any other medical care, we trust that a person and their physician and their family can make those decisions together, and they don't need legal intervention in that decision making process that prevents them from getting the care that they need. And so why would women's care be any different than that? And yet here we are in a very difficult position for many women because of those restrictions.
Right. I mean, and as you say, if someone decides that there's a cancer treatment out there that could save them, but they don't want to take it, and it means they might die, well, that's their choice. But somehow this is different. Somehow women are not given that choice in this situation.
That's right.
So anyway, and I just can't thank you enough for all you have done. I think, most of us in Indiana know about the controversy concerning your Torchbearer Award that was secretly and strangely taken away by, I'm sure at the hands of the evil Todd Rokita, our clown attorney general in Indiana. And I'm glad that you are getting the recognition that you deserve. It is ridiculous that that you would be publicized in a negative way for all that you do. And I'm so happy that we're able to recognize you among many, many, many important people for the good you do, for all the good you do, and how much you care.
Thank you. I appreciate that a lot.
Yeah. All right. Well, thank you so much for taking the time out of your busy day. I know you're super busy,
sure.
And I really appreciate you giving me a moment to talk about all this. But it's difficult stuff, but we just have to talk about it. We have to keep talking about it.
No, I appreciate it, and I appreciate the work that you're doing, not just to get women elected, but also to have these difficult conversations throughout the state to help people understand why this is so important. And again, just on the back of Ohio's victory in terms of, the people of the state voting to preserve this care for the people in their state. I think that is exactly what would happen here in Indiana if we had the ability to have a referendum. And it just speaks to the importance of continuing to have these conversations and to make change in our state.
Yes, I agree so much that yes, if all Hoosiers could vote on this, I think we would vote the right way. I mean, just like they have all over the rest of the country. It's ridiculous.
That's right.
All right. All right. Thanks again, Doctor. You're awesome. You know,
Thank you.
hang in there and just know that we are with you.
Thank you. I appreciate that.
All right. Take care.